Hi and welcome everyone. I am Pilar Sanz, Clinical Head at Ace Alzheimer Center Barcelona. As the host of this session, it's my pleasure to introduce the second session of this online summit. At Ace Alzheimer Center, we have always clear purpose to bring the Alzheimer's diagnosis, treatment, and research to a whole new level. Today, we are a renowned organization all over the world with a team of more than 100 professionals. Since 1996, we have diagnosed over 38,000 people, collected over 22,000 biological samples, and led more than 150 clinical trials. This, along with the national and international research projects that we have led, has allowed us to become more and more present in the scientific highlights of the last decades. And I am proud to say there is so much more to come. Now, let me introduce the chair that will be moderating this session. Dr. Jean-Paul Taylor is a professor of translational dementia research at Newcastle University in the United Kingdom. Dr. Taylor's research focuses the application of neuroimaging and neurophysiological approaches in understanding symptomatology in dementia with Lewy bodies and Parkinson's disease dementia, as well as developing better management approaches for people with Lewy body diseases. Currently, Professor Taylor is the NIHR Newcastle Biomedical Research Center lead for dementia, and he is the chief investigator of the NIHR HTA COBALT trial, which is investigating the benefits of memantine as an add-on therapy to cholinesterase inhibitors in dementia with Lewy bodies and Parkinson's disease dementia. Welcome, Dr. Taylor, and thank you very much for moderating this session.
Thank you very much for that introduction, and a big thank you to ACE Global Research for organizing this event. Today's topic is dementia with Lewy bodies, or DOB, and in particular the heterogeneity which is expressed in this condition. We have two excellent speakers today, Dr. John Toledo, who will set the scene with regard to DOB, its stages and protein presentations, as well as addressing the key issue of co-pathologies. Dr. Pierre Borghammer will then take us on a journey of the potential origins of DOB, speaking to the brain first and body first hypothesis which he has pioneered. To introduce this session, I thought it would be helpful to draw on my personal experience as a clinician who sees people living with DOB. People with DOB can experience a panoply of different symptoms which has major impacts on their quality of life and day-to-day function. Clearly, this can range from cognitive difficulties, but in particular, the marked cognitive fluctuations which they experience. They may also experience marked psychiatric symptoms. An example of this is the complex visual hallucinations, and this can be coupled with Parkinsonism, as well as a raft of autonomic symptoms, for example, orthostatic hypotension. DOB patients also experience a range of sleep disturbances, the archetype being REM sleep behavior disorder, and they also suffer from arousal difficulties. There is a significant range of symptoms which are experienced and expressed by different patients and a marked degree of heterogeneity, and this is particularly marked in the early stages. Furthermore, the severity can range quite considerably between patients, and within patients, the symptom severity can fluctuate considerably over time. As a clinician, when we treat one symptom, sometimes this can lead to the worsening of another, a tug of war. And there's variable treatment response between individuals. These wide-ranging symptoms and heterogeneity can make this condition very difficult to diagnose and manage. I will now present some clinical vignettes of people I've seen in clinic to demonstrate the challenges and help set up the subsequent presentations by our excellent speakers. The first case is a 64-year-old gentleman, retired postal worker, who was referred to my Lewy body disease clinic by local movement disorders service. He had a long-standing history of constipation and a more recent history of subtle Parkinsonism with slowed walking, stiffness, and a quiet voice or hypophonia. He also experienced dizziness on standing, and there was evidential postural hypertension. Recently, he had begun to experience having vivid dreams and acting out these dreams, and subjectively, he felt slowed in thinking. On objective assessment, his MOCA was 26 out of 30, with some subtle executive dysfunction. An MIBG study was done as part of a research study showing reduced uptake. His structural MRI was unremarkable with no major atrophy, and the initial diagnosis was probable MCI Lewy body. In follow-up, unfortunately, he had unacceptable side effects to cholinesterase inhibitors, and he had a subsequent rapid deterioration over the next 6 months with the manifestation of refractory to treatment hallucinations as well as cognitive fluctuations. Sadly, he died in hospital following a fall, having experienced a possible aspiration pneumonia, and this was about 9 months after the diagnosis initially. In the second case, a 72-year-old former librarian was experiencing visuospatial disturbances and pareidolias when he came to my clinic. He had subjective difficulties in perceiving objects in 3D space, sometimes missing his dinner plate or tripping over curbs. He also complained about frequent illusions and pareidolias, and indeed admitted having some intermittent hallucinations of children and people in his house, although he wasn't distressed by these. He didn't have any sleep disturbances, cognitive fluctuations, or other supportive features of DOB, and he was maintaining his activities of daily living. On the Addenbrook's cognitive examination, he scored 85 out of 100, with subtle visuospatial and executive deficits, but relatively preserved memory. I noted on examination that there was slowing of his gait, but he had a history of lower limb osteoarthritis, and there was no overt Parkinsonism. On MR scanning, he had mild generalized atrophy, and he also had a DAT scan and an MIBG, both of which were negative. The initial diagnosis was possible Lewy body MCI. I've seen this gentleman in clinic over the next 5 years, and it was a very gradual change in his presentation, with a decline in his cognitive function. He did show a good initial response to cholinesterase inhibitors and memantine. He then began to manifest more obvious Parkinsonism with a worsening gait and a subtle tremor. A repeat DAT scan at this point noted that this was positive, and he was needing increasing familial support with activities of daily living, including medication prompting, as well as support with shopping and bills, etc. The revised diagnosis was then probable DOB. In the third case, this was a 78-year-old woman and retired school teacher who was brought to the memory clinic by her daughter due to progressive cognitive difficulties over the past 2 years. She presented with prominent memory problems, repeatedly forgetting conversations, misplacing objects, and these were having a functional impact on her daily activities. On the Addenbrook's cognitive examination, she scored 68 out of 100, deficits in memory, attention, visuospatial function. Her MRI demonstrated mild bilateral hippocampal atrophy, and my colleagues made an initial diagnosis of probable Alzheimer's disease dementia. However, over the next 2 years, whilst the memory deficits progressed significantly, despite cholinesterase inhibitors, she manifested fluctuating attention, and her daughter described episodes of staring blankly into space. She also began to experience complex visual hallucinations, seeing rats around the house, and she was referred to my clinic. You will note that her cognitive scores had dropped, but she still maintained a prominent antegrade memory deficit. She also had a subtle Parkinsonian gait and mild bradykinesia without significant tremor. Her DAT scan was abnormal, consistent with dopaminergic deficit, and a research-based amyloid scan was positive. The revised diagnosis fitted with probable DLB criteria, but likely Alzheimer's co-pathology contribution. So these cases demonstrate the heterogeneity of DLB presentations. Some with a rapidly progressing features, others with a much more gradual course. And yet other patients may present with an overt Alzheimer's presentation, yet then begin to manifest DLB symptoms. So as a clinician, I wish to pose these questions. Why are my patients so different from each other? And how does this influence how I diagnose, prognosticate, and treat them? So this now leads into the main presentations. I'd first of all like to introduce Dr. John Toledo, who is a clinical academic neurologist at Houston Methodist Hospital in Texas and Cornell University. Dr. Toledo has been at the vanguard of advances in neuropathology and biomarkers. And relevant to DLB, he has been the lead author for the International Neuropathological Consensus Criteria for the evaluation of Lewy body pathology. He has a specific interest in understanding interactions between different and coincident pathologies in neurodegeneration, and then relating these to the clinical endophenotypes, in particular DLB. His work is clearly opposite to our questions regarding the wide heterogeneity evidenced in DLB. So over to you, John.
Hi, good afternoon. Thank you, Jean-Paul, for the kind introduction. This afternoon, I will be talking about updates in dementia with Lewy bodies, mainly focusing on the prodromal stages and how newly described heterogeneity and biomarkers affect how we practice and the clinical prognosis. This is the outline of my presentation. So we will briefly review the clinical criteria for dementia with Lewy bodies. Then we'll move on to prodromal stages, describe the co-pathologies, and later on explain how we can use biomarkers and what they show us. First, we'll review the criteria for dementia with Lewy bodies. Dementia is essential for the diagnosis, but what makes specifically the diagnosis of DLB is the presence of core clinical criteria, which are fluctuations, visual hallucinations, RBD, and Parkinsonism. Fluctuations can affect cognition, alertness, and arousal. Visual hallucinations are the more specific and characteristic, but people with dementia with Lewy bodies can also present other type of hallucinations. RBD frequently presents before the diagnosis of dementia. And compared to Parkinson's disease, Parkinsonism only requires one of tremor, rigidity, or akinesia, bradykinesia. Postural instability is not part of the core clinical criteria for Parkinsonism, but is part of the supportive clinical signs and symptoms. Due to constraints, we will not be covering them today. Indicative biomarkers are reduced dopamine active transporter activity measured through PET or SPECT, decreased MIBG myocardial scintigraphy, and PS polysomnography documented REM sleep behavior disorder. Then there are also supportive biomarkers, which is relative medial temporal lobe volume preservation, the presence of cingulate island sand or occipital hypometabolism in FDG PET, and we will be reviewing this later, and also some slowing that is observed in EEG. To make the diagnosis, we need the presence of either a probable for the probable DLB diagnosis of the essential dementia clinical syndrome, plus at least two of the core clinical criteria early in the disease, or the essential criteria, one core clinical criteria related to disease, and one indicative biomarker. But there are many symptoms and signs that are present in dementia with Lewy body. So several psychiatric symptoms, autonomic symptoms. We talked briefly about arousal and motor, and also some other non-motor like hyposmia. Unfortunately, this diagnosis is not frequently recognized, and based on the previous set of criteria, the sensitivity was only 32% in autopsy samples, and also is often tied to a diagnostic delay, and people with this condition need to see multiple physicians over multiple visits to be diagnosed, and often the first diagnosis is not the correct one. One thing that we know about neurodegenerative diseases is that they don't happen from one day to the next. They happen over a long time. So in general, for all of these conditions, we are born with a healthy brain, and there might be some risk factors that happen throughout life. And here is important lifestyle intervention for prevention. Later on, we reach the preclinical stages that now that we get more and more biomarkers, we are able to detect during life. And here is when we see biomarker changes, but not clinical changes. Then we have the prodromal stage, which in dementia with Lewy bodies can affect cognition, and we will talk about the profile, either executive or memory. Also, there is the autonomic symptoms, there is the Parkinsonism, and there are the hallucinations. And later on, unfortunately, symptoms become more severe, and the dementia diagnosis is reached. We have more information from the Alzheimer's disease and the Parkinson's disease world, and there are now very well-established models of when biomarkers change and how long they change before a dementia diagnosis or a Parkinson's diagnosis is established, and we know now is more than 10 years. But let's talk now about the prodromal stages of dementia with Lewy bodies. So the most well characterized is the MCI, which is defined by here we will switch the essential criteria from dementia to mild cognitive impairments. Core clinical criteria remain the same. The proposed biomarkers are the indicative biomarkers, and the potential biomarkers are more or less an iteration of the supportive biomarkers. Then we have the delirium onset. And so here we need to think about the delirium onset DLB when the delirium is unprovoked, when it's prolonged or recurrent, or when it's followed by cognitive decline. And so people with late onset delirium are at greater risk of dementia with Lewy bodies. The third presentation is psychiatric onset. The most frequent presentation in psychiatrically is major depressive disorder or psychosis, which can present as delusions or hallucinations. And in these cases, it's helpful to look for other features like motor signs, cognitive deficits, and REM sleep behavior disorder. This is a summary of the first symptoms that were observed retrospectively looking at charts of people with DLB. And what we can see is when we are looking for the first symptom that presented in isolation, 1/3 of the times is cognitive, but many other times is other of them. And we see here some of the things that we discussed before. However, very frequently, you can see in the same series, so there were around 75 people who had more than one. And in these cases, cognitive symptoms are very frequently present. How does this look compared to Alzheimer's disease, the most frequent dementia? So there are more frequent non-cognitive signs and symptoms compared to DLB, in DLB. And when we looked at the distribution of them, we see how psychiatric, delirium, motor signs, anosmia, and RPD are more frequent in prodromal DLB compared to Alzheimer's disease at the MCI stage. How is the clinical profile? So before the criteria were written for prodromal DLB, it was seen that when people have amnestic MCI, especially a single domain, most of them would progress to have probable Alzheimer's disease. However, when it was non-amnestic, especially this executive, these individuals more frequently would go to have a DLB diagnosis. And here you can see the survival models for this progression. Regarding the test, so this is a recent meta-analysis that shows that in people with Lewy body mild cognitive impairment versus mild cognitive impairment due to Alzheimer's disease, those with the Lewy body disease had worse test or scoring in attention in terms of processing speed and executive, but did better in terms of immediate recall and delayed memory. Another proof that there is this idea of the mild cognitive impairment due to Lewy body is useful is that when these individuals are followed longitudinally, there is a stability of the diagnosis in the sense that most of the people who have a probable MCI due to Lewy body go to a DLB diagnosis, and the same thing, most of the individuals with an MCI due to AD go to this diagnosis. So these are useful constructs. We briefly mentioned before RBD. So REM sleep behavior disorder, which is the enactment of dreams in the REM sleep phase of sleep, which polysomnographically is characterized by the absence of atonia in these states, is associated with a high risk of progression to an alpha-synucleinopathy. And here we can see the numbers of a large study where more or less in 8 years, half of the people progressed to either Parkinsonism or dementia. More or less, it was half and half, with 52% of the individuals progressing to Parkinson's disease, 43.5% progressing to dementia with Lewy body, and a smaller number, 4.5%, progressing to multiple system atrophy. Also, at the RBD states, there is a greater impairment in executive testing, cognitive test, and here we see how the trial-making test is the one that shows greater differences at the RBD states. And this was in a group of RBD individuals who 1/3 of them had mild cognitive impairments, the other one didn't have a cognitive impairment. What about the other two prodromal categories? They are not so well characterized, but it has been shown that compared to Alzheimer's disease, individuals with DLB have a higher number of episodes of delirium 1 year and before and after diagnosis compared to Alzheimer's disease that lead to a higher rate of hospitalization. Regarding the psychiatric onset, depression is the most frequent, and the psychotic symptoms are not so frequently present, but throughout disease, they become very prevalent, being present in around 80% of the individuals. But what about copathologies? Does DLB happen on its own? Neuropathological studies have shown that there is high prevalence of copathologies, most frequently Alzheimer's disease and cerebral amyloid angiopathy occurs with Alzheimer's disease. And also in clinical studies where CSF lumbar was obtained through lumbar puncture, around half of the individual were along the Alzheimer's disease continuum. So this could be that they had only amyloid positive measures in the CSF, or they could have also a positive tau, or they could have atrophy on the MRI. Does this matter? So in the previous study, it was shown that individuals with DLB who also had Alzheimer's disease positive biomarkers progress faster. And in a neuropathological study, we also saw that individuals who have Lewy body and AD pathology tend to progress faster than other individuals. Also, the presence of Lewy pathology is an independent predictor of worse performance in executive tests, and the AD pathology leads to more impairment in cognitive measures. Recently, it was shown that some of these biomarkers also may have a prognostic implication in RBD. So this is a large study where people got lumbar puncture, and as you can see, 3/4 of the individuals with RBD had positive CT amplification studies in the CSF. We'll talk about that later. And the question is predicting who went to get a diagnosis of PD versus DLB. Changes in the DAT scans were more associated with a conversion to PD, whereas changes more severe hyposmia, the presence of mild cognitive impairment, and AD biomarkers were more predictive of progression to dementia with Lewy bodies. And one interesting fact is that the independently mild cognitive impairment and AD biomarkers were predictors of progression to DLB, but in the multivariable model, only MCI was a predictor. There is another study that was published this year that showed that the blood biomarkers of Alzheimer's, in this case, a beta 42/40 ratio and phospho-tau 181, were also predictors of progression to DLB compared to PD. So we mentioned briefly the biomarkers. DAT scan is the most frequently used. It has a sensitivity of 80% and a specificity of 92%. One thing is it needs to be recognized that abnormal DAT scan is not only present in Parkinson's disease or dementia with Lewy bodies, it's also present in PSP and MSA. Something that is more characteristic or typical of DLB is that there might be a balanced loss instead of an asymmetric loss in earlier stages compared to Parkinson's disease. The other one, and Per will be talking more about this later, is changes in MIBG, where you can see that there is a change in the part-to-mediastinal ratio, and the sensitivity is 80%, specificity is 92%, but compared to the DAT scan, this is not affected in PSP or MSA. Regarding FDG PET, here we have the cingulate island sign. And what it's saying is that there is a preservation of the posterior cingulate. However, autopsy studies have shown that as there is an increased amount of AD pathology, the cingulate island sign is not so useful. And here you can see that the higher values are more characteristic of a cingulate island sign, but as AD pathology increases, the cingulate island sign disappears. So it's not so useful in the presence of the AD copathology, and it's also present in posterior cortical atrophy, which is also more frequently has an underlying AD pathology. Regarding CT amplification assays, so in this test that have been recently available for research and now moving also into clinical practice, what it does is it analyzes how this misfolded alpha-synuclein that is present in the CSF affects normal or wild-type synuclein, and this later is measured over several cycles. The other test that has been also recently brought to research and is moving to practice is skin biopsies, but this is not a CT amplification assay. Here is an immunohistochemical assay that measures phosphorylated alpha-synuclein in the skin. Regarding the CT amplification assay in the CSF, they don't detect, so they are not always positive in cases of amygdala-only alpha-synuclein, so when it's more circumscribed, but when the pathology extends to the limbic and the neocortical areas, is more sensitive, and this test is also highly specific. However, and this is something that we will need to follow over time, in in clinical cohorts that have a probable diagnosis, around 72% of the individuals have a positive alpha-synuclein assay, so similar numbers of what we saw in RBD. And something that has been consistently shown in the PD and in other Lewy body cohorts is that the presence of hyposmia is associated with a greater probability of a positive seed amplification assay. Also in RBD, these studies have shown that having an CSF positive alpha-synuclein assay is associated with a greater risk of progressing from RBD to PD or DLB. And lastly, I will be covering alpha-synuclein biomarkers in the skin. So they have a high sensitivity and specificity in clinical cohort in Parkinson's disease. Sensitivity has been lower in the prodromal stages in like RBD, and a recent study that included individuals with probable DLB diagnosis, it showed high sensitivity and also a high specificity. In my last slide, I will briefly talk about how this affects clinical trials and probably practice in the clinic. And it's like, first, we want to identify what states is the one we think is best to treat with the drug we want to treat. Then we want to confirm the diagnosis of DLB with biomarkers that are measuring or alpha-synuclein. Later, we want to evaluate for pathologies, and this has implications for progression, stratifications, and probably in the future for personalized treatment addressing multiple pathologies. And this is already happening in clinical trials, like in the neplamapimod clinical trial in phase 2A, there was a difference in terms of the motor and cognitive symptoms based on having high or low phospho-tau in the blood. And so in the sense that individuals who were having normal phospho-tau levels did better. And this informed the design of the phase 2B of the trial in terms of selecting individuals who were not expected to have AD pathology. Thank you very much for your attention, and I hope to discuss now with the other speakers what we have presented today.
Thanks so much, John, for that wonderful presentation. I will now like to introduce Dr. Pierre Borghammer, who is clinical professor at the Department of Nuclear Medicine and PET at Aarhus University Hospital. He is a renowned clinician scientist and nuclear medicine specialist, and he's been at the forefront of multimodal imaging and related works in Parkinson's disease and Lewy body dementia. Dr. Borghammer has a strong interest in understanding the fundamental aspects of pathophysiology and the etiology of neurodegenerative diseases, especially to expand our knowledge of the underlying subtypes and their causes. In particular, he has been responsible for the provocative and exciting brain-first, body-first hypothesis of how Parkinson's disease and conditions like DLB might originate and spread in the body and brain. Over to you, Pierre.
Thank you very much, John Paul, for that nice introduction. So I'm going to talk about body first and brain first Lewy body disease. And when I say Lewy body disease in this presentation, I am actually going to speak about both Parkinson's disease and dementia with Lewy bodies, since this model I'm going to talk about doesn't really distinguish between the two. But that would be clear from the presentation. So initially, I'm just going to do a brief introduction about the idea, and then go through a little bit of evidence from clinical data, imaging evidence, and post-mortem evidence. So I'm going to just briefly start with the Bragg hypothesis proposed by Heiko Bragg in 2003. Very influential idea. Bragg suggested that the pathology starts in the gut, spreads through the vagus, and then goes up and up through the brain. That idea seems to fit with the known fact that many patients develop constipation before diagnosis, They also, some of them develop REM sleep behavior disorder before diagnosis. This comes from the pons, which is below the dopamine system. That's why it comes before the diagnosis. Once the dopamine system is affected here, that is when the patient gets the diagnosis. So as I said, tremendously influential and important hypothesis, but we have also known for many years that it's probably incomplete. And just to mention 2 points here. So again, if we look at patients with Lewy body disease, Parkinson's disease in this case, only 1/3 of patients actually develop constipation and RBD before diagnosis, and the rest do not. Also, this is a busy table from a post-mortem study from 2008. And the only point here is that the first 25 cases, they do not have any pathology in the vagus nucleus down here, which is the place that Bragg said that it always started. So clearly some cases do not follow the Bragg staging. So the brain-body idea is basically a newer version to a certain extent. Body-first Lewy body disease on the left is very similar to what Bragg proposed. The pathology starts in the gut, spreads through the vagus here, but it also spreads via the sympathetic system to the sympathetic trunk. And this is the route by which it reaches the heart very early. In the brainstem, it goes up to the locus coeruleus. This is probably the time when the olfactory nerve and bulb becomes involved, and then it goes further up in the brain. So that's body-first disease. Brain-first disease, we believe, in most cases start in the olfactory bulb, spreads to the amygdala, reaches the nigra very early, so the prodromal phase here is probably much shorter. But then eventually the pathology spreads in the other direction, and at the end stage, if you will, it also goes to the peripheral nervous system. So at the end stage of disease, the pathology is kind of everywhere, and the two types are very similar, but initially they're very different. We believe about 45% are body first, 45% are brain first, and then there are less than 10% that are kind of not really compatible with these two concepts. And here I'm talking about all patients, so a combination of Parkinson and DLB. Now, if we look at the body first group, here it's actually only 1/3 are Parkinson's disease, or excuse me, 1/3 of Parkinson patients are body first, whereas 2/3 are brain first. And it's opposite with dementia Lewy bodies. So why would we say that? If we look at REM sleep behavior disorder before diagnosis, so this would be the body first, because when it comes before diagnosis, the pons is getting hit here earlier than the nigra. That is only 1/3 of Parkinson's. On the other hand, in dementia Lewy bodies, it's probably at least 2/3 of patients that develop it before diagnosis. So this suggests that dementia Lewy bodies are more of a body first type. Furthermore, if we look at a study like this shows you, for instance, constipation. And here you see dementia Lewy bodies and Parkinson's. And this is years before diagnosis. So dementia Lewy bodies have more constipation many years before diagnosis. They have more hypertension problems up to 8 years before diagnosis compared to Parkinson. And they have more problems with the urinary system up to 6 years before diagnosis. So again, suggesting that DLB is more of a body first type with more body first symptoms many years before diagnosis. Okay, so at this slide you see here is a very typical slide. It's kind of one image of what is Parkinson's disease. And it's very nice if you only show one figure. But in fact, again, it's too simplified if we want to talk about more than one type, because only 1/3 of Parkinson's develop constipation before diagnosis and 1/3 RBD, and these patients tend to be the same. So in fact, this type of figure is actually mainly representative of body first disease. And we also need to show this figure, which is more representative of brain first disease. And in this case, the patients actually have few and mild non-motor symptoms before diagnosis, except perhaps hyposmia. But they can develop these symptoms after diagnosis, such as RBD and constipation, but it comes after diagnosis in brain first. And again, if we combine Parkinson's and dementia Lewy bodies into one pot here, we would say that approximately 50% follow each of those two trajectories clinically. Okay, so moving on to some post-mortem evidence here. So this figure on the right here is, exemplifies where is the Lewy pathology at the time of diagnosis. And both in Parkinson's and dementia with Lewy bodies, the pathology has spread almost everywhere the day the patient gets the diagnosis. So if you want to, guess where did it actually start, it's a little difficult because it's so widespread. So therefore, it's very important to study very early cases, what we call incidental Lewy body disease, where the pathology has not spread very far, because then it's easier to guess, if you will, where did it come from. And we did such a study in collaboration with 3 groups of neuropathologists. We had in total 528 Lewy body positive cases. Among those, we isolated the approximately 1/3 of cases who only had pathology in a few places. And when we did that, 2 patterns emerged. Either the pathology is kind of down here, brainstem or below, or it's in the olfactory bulb and the top part of the brain, but then it's not in the bottom part. So this is the Japanese data set, and we have only cases with pathology in 1, 2, 3, or 4 places. So there were cases with pathology in red and yellow regions. Red regions here, limbic, olfactory, top of the brainstem, but then they have absolutely nothing down here. Other cases are the opposite. They have blue and yellow, meaning they have pathology down here and the top of the brainstem, but then they have nothing in the amygdala, nothing in the olfactory bulb, and only 7% did not fit these 2 categories. In a Finnish data set, it's the same, red and yellow, like here, blue and yellow, like here, and only 5% didn't fit. And another Finnish data set, red and yellow, blue and yellow, and only 8% do not fit. So that means in total, these early cases, 46%, they look like this. They have only pathology down here. 47% have only pathology here. And then there are rarer cases, less than 10%, that do not fit with these 2 categories. And of course, we believe that these 2 initial patterns of pathology tells us that this type is body first because it came from the autonomic system, whereas this is brain first, where it probably came from the olfactory bulb in the nose. Okay, so moving on to imaging evidence, and here I'll talk mainly about heart imaging, the sympathetic system of the heart, imaged with MIBG, and dopamine of the dopamine PET of the dopamine system. So if we want to test this hypothesis, the brain-body hypothesis in humans, this is what we would do. Very early brain first are only sick in the brain, if you will, so they have a pathological dopamine scan, but the body is still normal, so the heart is still normal. Body first disease is completely opposite, very early on. It starts in the body, so the heart scan is pathological, but the brain is still normal, so here the dopamine scan is normal. And this is exactly what we found. Here you see the brain axis. To the right here, you're normal. The body axis of the heart, up here you're normal. So the top right corner, they are healthy controls. They are normal on both scans. Blue patients are body first. They all developed REM sleep behavior disorder before diagnosis. And you can see they start by moving down, losing the heart first, and then left, losing the dopamine system later. Brain first patients in red, these are patients without REM sleep behavior disorder, without constipation. They have the opposite trajectory. First they move left, losing the dopamine system first, but a normal heart. And then they later start to move down as they start to lose the heart innervation. And we have also studied these patients with longitudinal imaging. We are following them all. This is just a small snapshot, but you can see that, this is 3 years and 6 years follow-up here and 3-year follow-up here. And all of these patients are kind of progressing along these trajectories to this bottom left corner. Just want to mention that studies like these are very complicated, so it's really a team effort. I want to acknowledge my team for making all of these complicated studies. Yeah, I think I'll skip that in the interest of time here. I'm sorry. Okay, This is a slide about the heart imaging specifically. All of these patients here are Parkinson patients. And up here, you're normal. So these patients have a normal heart. Down here, it's very abnormal. When you have a normal heart, it looks like this. These are 3 different cases. It's more, the signal is above the lungs here, you can see. When you have lost 50%, you can still see the heart, but now it's at the same level as the lungs. And 75%, there's a pale shadow left, and 100%, it's completely invisible. And the point here is that this does not happen overnight. This takes a lot of time. It actually takes about 11 years to go from being normal to having lost 75%. And how do we know this? Because we have a new data set, 200 longitudinal heart scans from Korea. We have modeled it, and we have shown that it takes about 11 years to lose 75% of the innervation. And this is important because, again, this is the one I showed you on the previous slide. Remember, these are REM sleep behavior patients, and they have lost about 75% of the heart innervation in general. They used to be here as healthy controls. So to go from here to here takes about 11 years. It's very slow. And then it'll take an additional 8 years before these patients convert to either Parkinson's or dementia with Lewy bodies. And so this is in itself a very powerful argument for calling it body first, because these patients have the degeneration in the body, in the heart, has been going on for more than 10 years, while the brain, the dopamine system, is still normal. Okay. There's another point of the brain-body idea that relates to symmetry and asymmetry, because many Parkinson patients show asymmetric symptoms. It's worse in one side than the other, and the scans can be asymmetric like this, but some patients are more symmetric with more symmetric scans. And in the brain-body first idea, we believe that the brain-first patients, they tend to be much more asymmetric on average, whereas the body-first patients tend to be more symmetric. And remember that dementia with Lewy bodies are more body-first, so they should be more symmetric, whereas Parkinson's disease are more brain-first, so they should on average be more asymmetric. And that's what we showed. So this is, again, human dopamine scans. And here we have an asymmetry axis. Healthy controls are very symmetrical because they have healthy symmetrical scans. Early Parkinson's disease, body first, most of them are symmetric because they have lost both the left and the right system, if you will. But most of the brain first cases are much more asymmetrical because they have mainly a loss on one side. So we published this 4 years ago. This is a new cohort we are building right now. So this is unpublished data, new patients, much bigger cohorts, and you can see exactly the same thing. 71% of brain first are quite asymmetric, whereas only 32% of body first are asymmetric. And finally, this is about DLB. Remember, DLB patients should be more symmetric. You can see here 80% of newly diagnosed DLB have symmetric dopamine loss. And here we then compare to 80 Parkinson patients newly diagnosed. And here you see that 2/3 are asymmetric. So DLB is much more symmetric than Parkinson's, again supporting that it's a more of a body first type. Okay, so the next question would be, why on earth should body first Lewy body disease give you faster dementia? And so the short answer to that question is I don't know, but I'm prepared to speculate. So I think the reason is this. So at the time of diagnosis, at least in Parkinson's, in Parkinson's, we diagnose the patient based on the dopamine system because we diagnose the patients once the Parkinson motor symptoms appear. At that time, we believe the pathology looks like this. In body first, there's much more pathology in the brainstem, and it's bilateral, it's symmetric, whereas in brain first, there's much less in the brainstem, and it's asymmetric. So brain first patients, they have a reserve capacity in the less affected hemisphere. Now, body first have more pathology in the brainstem, it's more symmetric. It involves all of the key neurotransmitter systems, the NIGRA, the PPN, the RAFA, the serotonin, the locus coeruleus, noradrenaline, the nucleus basalis of Minard. Now, if you have affection of all of these systems in both the left and the right side, it can by itself give you subcortical dementia, but it's also actually a perfect distribution system to distribute alpha-synuclein throughout the entire brain, because that is what these systems do. They innervate the entire brain. So it might also lead to much faster cortical Lewy body disease compared to brain first. That's what I write here. So I think this is the reason for why body first in itself gives you faster dementia. But when we talk about dementia in general, and also in the context of Lewy body disease, it's also important to talk about Alzheimer's co-pathology. And that's what I'm trying to show here. So I believe here on this axis, this is the Lewy body axis. And if you have body first disease, this will push you towards faster dementia. But we also have an Alzheimer axis. And if you have moderate or high amounts of Alzheimer co-pathology, this will also give you faster dementia. So I believe one way of looking at clinical dementia with Lewy body disease or Lewy bodies is that these patients are very commonly found in this top right corner. They have a combination of body first disease. They have early RBD, autonomic problems before diagnosis, and then most of them have Alzheimer co-pathology. So these two things push patients towards so fast dementia that they actually get the dementia with Lewy body diagnosis. Now in this corner, if you have brain first disease without Alzheimer's co-pathology, these patients will always get a Parkinson diagnosis. If they get demented, it will take many, many years to get there. And then the two remaining quadrants are kind of in between. I think most of these patients get the Parkinson diagnosis with a bit faster progression to dementia compared to these. And a few patients here can also get a dementia with Lewy body diagnosis. For example, we know that perhaps 20–30% of dementia with Lewy bodies do not have Alzheimer co-pathology. So they must come from this corner down here, I believe. So that was the end of my talk. So I will just give you a brief summary here. So I talked about body first and brain first disease. So this is the concept. Body first disease starts in the gut, spreads via the vagus, the sympathetic system. It's quite similar to the Bragg ideal. Brain first, in most cases, starts in the nose, goes via the amygdala to the nigra, and then spreads in a top-down direction. When you look at clinical symptoms, we can speculate, we know based on clinical studies that some patients, they have RBD and autonomic symptoms before diagnosis, so they have the clinical body first type. Other patients do not really have a lot of symptoms before diagnosis, so that's the clinical brain first type. When we look at imaging, I showed you that we see these two patterns that are almost non-overlapping. Either you lose the heart first or you lose the dopamine system first. When we look at postmortem in the earliest cases, we see that there's almost a 50-50 distribution. Almost 50% have only pathology in the bottom of the brain to begin with, whereas the other, about 50%, only have pathology in the limbic system and the olfactory bulb. And finally, I suggested that dementia with Lewy bodies, in most cases, is a combination of body first Lewy body disease combined with Alzheimer's co-pathology. This produces a rapid dementia type, which we recognize clinically as dementia with Lewy bodies. And with that, I would like to thank you for listening, the funding bodies, and most especially all of the study participants, the patients that were involved in our studies. So I'm tremendously grateful for their contribution. Thank you very much for listening.
Thank you, Pierre, for that. That was absolutely wonderful to have that journey through the body first and brain first hypothesis and the evidence for these. It's wonderful. And also big thanks to John as well for his earlier presentation. So this is now the floor for questions. So please do post your questions. We're looking forward to receiving them and having an active discourse. So I think, Hila, you would like to ask maybe the first question.
Thank you very much, Jean-Paul. Thank you, Per and John, for your outstanding and very didactic presentations. I think now we all have a conviction that the brain first and body first classification has a very significant result in diagnosis and also in prognostic implications. Then what do you think about the possible differentiation between sympathetic and parasympathetic body first types? Do you think can have also this type of very significant implications, clinical, diagnostic, and prognostic implications?
Oh, thank you very much, Pilar. I suppose the question was for me. I didn't get that, but anyway, yeah. I'm happy to answer. Thank you. Okay, so it's true. I actually didn't speak about it in the presentation, but we just published a paper where it seems likely that the body first in itself is actually two subtypes, mainly parasympathetic initially versus another which is mainly sympathetic. Okay, so and if we think about the clinics, it makes a lot of sense to me, because when we look at our prodromal body first, these are the patients in the sleep clinic with RBD, and we study those patients. Mm-hmm. They are actually pretty dissimilar. They are heterogeneous as well. Some of them have lots of hypertension problems. They have a completely invisible heart on the scan. I think those might be a sympathetic predominant type. And then there are others where the heart scan is abnormal, but you can still see the heart, and they don't have orthostatic hypertension, and they don't have as much constipation and that sort of thing, suggesting that it might be more parasympathetic. And then there's actually a rare diagnosis that we haven't discussed so much today, namely pure autonomic failure. I think it's underdiagnosed. I think these patients clinically, I think they could very likely be, most of them, a heavy sympathetic predominant type, mm-hmm. because they have massive loss on the heart scan. They have very severe problems with their hypertension, so much that they pass out if they stand up. But the brain is, as far as we can see, completely normal, more or less. So that fits to me with a disease that really attacks the sympathetic system mainly very early on for a long time before the disease really develops to other parts of the system.
Mm-hmm. Thank you, Per. And
thank you.
I don't know if we already have any question. Maybe not.
Yeah, carry on, Pilar.
No. Please, please.
If you have another question, please ask it, and then I will pose the question from the audience.
I was thinking about the comorbidity. We all know at this moment that the comorbidity is very important in prognosis. And I would like to know what do you think about the systematic determination of AD biomarkers in the DLB patients, and also, why not? What do you think about what do you expect of the possible treatment of these patients with anti-amyloid treatments?
So I think that's a question to you, John. So I think this is something that we all see and expect, and it takes some time to explain to people, but I always say, like, this is common like cardiovascular disease, that you not only have, like, in terms of risk factor, for example, hypertension, cholesterol, or people may have also peripheral artery disease, heart disease, or stroke. So I think once you put it in this and make the concept for neurodegeneration is something that is understandable in clinic. Also, I think an easy way to cheat the system is when at least when we look at the MRIs and we see quite a bit of atrophy in somebody who has a clear DLB phenotype, that's usually a telltale sign that there is also Alzheimer's copathology. And I often discuss this nowadays in clinic. It's a very interesting question regarding the treatment of the AD copathology with the new anti-amyloid treatments. So there was here in the US recently a grant opportunity to treat people with Lewy body dementia, so Parkinson's disease dementia and Alzheimer's, with these treatments. It was felt that we needed clinical trials because, for example, in people who have Alzheimer's, the effect of the anti-amyloid therapy, at least in the early dementia states, is like around 28% or low 30% of a benefit. So now, if we put it together with having mainly DLB or Lewy pathology, what's the benefit we can expect? So I think that's the question. Something also that is very interesting is like when we look, and Per can also comment on this, is that in general, people with Lewy pathology, those that have the highest amount of Lewy pathology are the ones that also have Alzheimer's pathology. So it seems like somehow, and there has been like some animal models where there is a kind of suggestion of co-seeding, but there might be some other mechanism. So the question is, how much are we addressing? And actually addressing AD copathology may also be helpful for Lewy body pathology. I think we don't know yet, but I think in the future we are going to be seeing it. Also, there is going to be clinical trials, or there are clinical trials that are treating amyloid and tau at the same time. So I think in the future we are going to see how we need to combine successful therapies treating different aspects, I would say, of dementia and movement disorders.
Here, I don't know if you wanted to respond or add anything to that.
Not much, actually. I think John pretty much covered it, but perhaps just repeat or emphasize that I think we have a lot of evidence in Lewy body disease to support that if you have Alzheimer copathology, it pushes you towards faster dementia. And there's this new study also that we saw today that in prodromal, so RBD, so these prodromal sleep patients, if they have Alzheimer copathology, they are at a much higher risk of developing demential Lewy bodies. If they don't, they develop Parkinson's disease. And if you had to choose among one of those two, you would choose Parkinson's disease, even though that's not good, but DLB is worse. So that suggests that I would really like to see a study where we attempt to treat prodromal sleep patients. We find the patients that are positive on the amyloid, and then we remove that amyloid with the Alzheimer treatments. And then we have the patients to wait 5-7 years to see if we can move them from getting dementia Lewy bodies to getting Parkinson's disease. Because I think we have enough evidence to believe that is possible. But of course, there's always ethical problems surrounding, giving quite a harsh treatment to prodromal patients that don't really have the diagnosis yet. So there's some problems there that we need to discuss before we can make such a study.
Thank you, Pierre. And actually, just to feed into this sort of general questions with regard to the body first and brain first, and this is a question which was posed by one of our audience members, is what are the factors, and this is $1 million or maybe $1 billion question, which are perhaps etiologically driving perhaps the body first compared to the brain first? And people have honed in on the microbiome, for example, peripherally as a sort of a generating agent within this sort of pathoetiology. Of course, there may be other things within the expososome which are important, and certainly genetics as well. So just wanted to, if you could comment on that, putting your model in that context.
Yeah, certainly. Okay, so regarding the microbiome, that was the question. So point number one, we know from many studies now that Parkinson patients and dementia Lewy bodies have a different microbiome than healthy people. Okay, so we know that. We also know that prodromal patients with sleep disorders, they also show some of the same differences in their microbiome. So these things suggest that there could be something with the microbiome as a trigger. The problem is that even the prodromal patients with sleep disorders, they have had the disease for probably 10 years already. So the microbiome changes in them it might be a consequence of the disease. First they get the disease, and that changes the microbiome, not the other way around. We simply still don't have solid data to either prove or disprove that in humans. In animals, however, there's lots of highly interesting data. And just to give one example, there's some bacteria, including some ordinary coli bacteria, they can produce a protein called curly. And they use the bacteria uses it for a good purpose, to make the biofilm such that they protect themselves against our nasty antibiotics. Okay, but that curly protein has been shown in the lab. If you take that protein and you put it into some normal synuclein, then that normal synuclein starts to form Parkinson pathology, you could say. So in that sense, we basically have a chain of events that's plausible. You have some bacteria in your gut that can produce this curly protein. If your gut is then leaky, the protein can then cross the gut barrier. And right on the other side, you have some very vulnerable neurons, some vagus neurons and some sympathetic neurons. And we know, it seems like that's probably where the disease starts in body first. So that nasty curly protein is actually just 2 millimeters away from those vulnerable neurons. It just has to cross that barrier. So it seems very, very plausible that could be, and that's, of course, is something that several labs, including we, are studying at the moment.
And what about the brain first? What would you speculate in regard to that in terms of perhaps environmental factors? Thanks,
Paul. So I think I will then just make a much broader answer and then say, so in body first, I just talked about microbiome, yes, but I think it could also be toxins, pesticides, industrial toxins that you also ingest, in your water, you eat them or whatever, you inhale them. They get into contact with your gut as well. They could also cause a body first, or simply infections. We also have evidence for that. And then in brain first, it seems probable to me that something you inhale, toxins, pesticides, that gets into your contact with the olfactory part of your nose, which is very close to that olfactory bulb. Or it could even be something as the common cold that all of us get all the time. And there would be no way to know this in human studies. We cannot study that in registry studies because we all get it all the time. So we wouldn't see the association. But that doesn't mean that it's not a trigger, because the common cold actually gives you quite a nasty inflammation in the nasal mucosa. That's another thing we are studying right now, if you can actually get Parkinson's disease from the common cold. Of course, you have to be vulnerable, have genetic vulnerability, or perhaps, and then you have to be unlucky someday that common cold just started a type of Parkinson protein, and because there might be some chance element in that. Okay, so everything I just said there is speculative. I don't want to say that because we have no hard evidence, but many labs are studying this.
Yes, and indeed, potentially quite a scary thought if we're heading down that route. I just wanted to perhaps cycle back to just bring in this idea with regard to the co-pathology, which John nicely introduced. And actually, I suppose ask you, Pierre, from your perspective, and you've also mentioned this with regard to the aspects of the Alzheimer co-pathology driving perhaps a more rapid progression, and the questions about whether the pathology, the amyloid, for example, might be the catalyst which then interacts or synergizes the alpha-synuclein pathology. So I wanted to ask, where do you see within your framework, body first, brain first, the Alzheimer co-pathology fitting into that story? And it would be really interesting to hear about how you're investigating this.
Okay, thank you. I'll try and give a short answer because I think John also has some good opinions here. Anyway, so very briefly, I think that these protein pathologies can synergize and can start each other. So I think that Lewy body disease eventually, once you get more and more of it, that can kickstart a secondary Alzheimer's disease pathology. And also the opposite. You can start by having limbic Alzheimer's disease, or in the classical regions, and that can then kickstart a secondary Lewy body disease in your amygdala or perhaps in the olfactory bulb. So I think both are. I think we have lots of evidence to suggest that is probably the case. So for my final point here, based on the work I've done, and when I look at the post-mortem data, especially when you compare the very early cases with those late cases where it's everywhere, what I see is that very early body first has nothing to do with Alzheimer's disease, because in very early body first, they do not have more Alzheimer's disease than people in the street in the same age. However, that's not in very early brain first. They have more. They have more Alzheimer pathology than they should have at that age. But then when you go to the not end stage, but when you have much later stages where you have lots more pathology, both brain first and body first, both of them have more. So that tells me that the body first, they didn't start with a lot of Alzheimer pathology, but they somehow got it. So that tells me that's probably the Lewy pathology that has kickstarted it by overwhelming the defense mechanisms of the proteostatic system. But I'm sure John will have some ideas as well there.
No, I think you explain it, and I agree with it. I think the other part that I was alluding before is like the proteostatic system. So basically, when you stress it, it affects at multiple levels, and then it's not able to cope like with additional problems, and especially the amygdala. I always think is like the kitchen sink of the proteinopathies, because you also find there TDP and everything. And from spending some time many years in the brain bank, like especially when you see amygdala predominant or amygdala only, you always tend to find AD pathology there. So there is no question of this. And as you explained very well, is that at the onset it might be more important for one or the other which pathology appears. And I think the other part is how, for example, in the body first with the RBD, how it decides how it's going to clinically progress towards a more motor or a more cognitive phenotypes. I think one of the challenges we are having as we understand things better and move to earlier and earlier diseases is, as Per said, is like probably those primary autonomic failure patients are not coming to our neurology clinics so often. They may be going more to cardiology, or the PCPs may not be thinking. Also, something very challenging when I was reviewing for the presentation is like psychiatric onset DLB, when we exclude the hallucinations, which are more prominent, and then hopefully often they might be seen as psychiatry, but they may recognize that they need to be seen also at neurology. But depression, so how we identify these people with late onset depression or anxiety to be evaluated in neurology clinics for risk of prodromal DLB, or even people who have hospital admissions for some other conditions and they have episodes of altered mental status or delirium one time, and then they may have said, well, it may happen just because during the surgery they may have gotten some opioid treatment or something happened, and this is it. We can just explain it like that, and then maybe 5 years later they develop DLB, and so I think that's kind of like the challenges of how to move to earlier stages. I think at this point it might be to better understand and classify these conditions, but I think in the future for treatments, because I think all the clinical trials in general in these fields are moving to earlier stages, which with the expectation that there will be a greater benefit, because none of the therapies that for the moment, or there is for many of them no expectation that they are going to be neurorestorative. They are going to try to prevent progression. And the other part is that the earlier we treat, the greater the benefit is going to be. On the practical part is like Per already mentioned that
we treat them, and then we will need to wait years and years to see if they would develop Parkinson's disease or DLB. So that's kind of the challenge of these early stages. They present an opportunity, but also a challenge from the study design perspective.
And actually, that feeds in nicely to one of the questions which has been posed. And by the way, please do post more questions for us. But this is in relation to biomarkers and particularly future biomarkers. And John, you picked up that we really need to be getting in there early and finding people at the early stage. Would you care to comment upon where you think we should be going with these early biomarkers, and what would be perhaps your choice of biomarkers to use in this space?
So at this point, we have different choices, and I think based on Per's presentation, some might be better depending in early stages, although we still don't have so much information of doing multiple biomarkers at early stages to identify. But we have several options. So one of them are these the scans that Per presented. The other options are the ones that I presented were the spinal fluid, where we have tests that can detect Lewy pathology. It seems like overall sensitivity is very good when we have limbic and neocortical stages. When we have amygdala, which is kind of very circumscribed, sensitivity is much lower, but at that point, we don't expect it to be symptomatic, but it can, of course, progress in the future. And then we also have the skin biopsies, where we are waiting for more studies with autopsy confirmation, but they are showing in clinical cases good sensitivity and specificity. It has been a bit lower in like one study they did with RBD. So the good thing is, or where a lot of the studies are moving, is we want to have biomarkers that detect the pathology. So we are speaking here about alpha-synuclein or Lewy bodies, amyloid, and tau. One thing that we are still missing nowadays, and this would not be a screening test, is a synuclein PET scan, which I think probably everyone here would be very excited, because it would be very helpful, especially with how the new PET scans, they are more sensitive and the images are better, and then we could better understand how all of these things progress and move in time, and also they would be very helpful to evaluate response to therapy. So the short answer to the question is yes, we have all these tests now that have good sensitivity and specificity. Some of them, I mean, like the DAT scan is also abnormal in the people who have other Parkinsonism. So basically is a marker of nigrostriatal pathway denervation. But the question is, who should we screen? How do we screen? And then there is a lot of questions. Per mentioned this about the ethics. So we have been doing this for some time in Alzheimer's, where we are using PET scans in preclinical stages. The thing is, Alzheimer's has a very high prevalence, like it's around 20% in people 60 or older, and even higher as you get older, and a very strong family history. So when people have 5, 6 family members across generations, there is a high expectation that they will have it. But then you need to explain and understand, and at this moment, this is something that is only done in research studies or in clinical trials that are addressing preclinical stages. So there is some complexity on who and how to do this testing and communicate.
Very, very valid points. Do you want to make any comments with regard to blood-based biomarkers? And then, Pierre, I know you're doing some really clever stuff with new radio tracers, whether you think that there would be any value in these more esoteric tracers in terms of the understanding and this early diagnosis. So John first.
Blood biomarkers, I think this is something that at this moment is very developed in Alzheimer's. So, and we have tests that we can do in clinic. I think we may be doing much less PET. For the synuclein, I don't think we're there yet. There has been some publications, but it seems like there has been some challenges replicating a blood test for alpha-synuclein.
Yeah, we're not quite there yet, are we?
No, we're not quite there yet with the blood tests, but I think it's, some of the studies look promising, and there are smart people working on that. So I'm optimistic that they will crack it. One thing that I'm less optimistic about concerning many of the biomarkers, again coming to the brain-body discussion, we have a very large hole in our evidence, and that goes for almost everything we do, because we almost don't study prodromal brain first, because we can't find them, because they don't really have any symptoms before they show up with either Parkinsonism or dementia. We know a ton about prodromal body first, because they're super easy to find, relatively easy. You go to a sleep clinic and you find the RBD patients, and then you can study them. Okay, so if we are studying biomarkers based on the periphery, skin markers, gut markers in your salivary glands, and perhaps in blood as well, and CSF, we know all of that in prodromal body first, and it works pretty well. And it should, because the post-mortem data shows that at body first patients, they have lots of peripheral pathology in the peripheral organs many years before diagnosis. But the post-mortem evidence also suggests that that's not the case for brain first. They don't have anything before diagnosis. They only start to develop it around the same time as they're diagnosed, and in some cases later. So the post-mortem evidence suggests to us that we should not expect that those peripheral markers will be positive 5 years before diagnosis. But we have no idea, because nobody has ever tested it, because we can't find the patients. And in my opinion, that's something that we don't talk enough about this. I think perhaps we are so enthusiastic about studying the RBD patients that we're kind of forgetting that it's only 1/3 of Parkinson's that we are studying, and we're forgetting about the 2/3. So anyway, so I'm personally trying to see if I can find prodromal brain first, but it's really difficult. So that's of course why nobody is really doing it.
That's a very good point, well made, where we have that lacune in our knowledge. I just wanted to sort of pick up a little bit about the medications, the questions being posed by Xavier Morato, talking about some recent trial results with regard to, there's the sigma-2 receptor antagonist CT1812. There's also the neflepimod trial, which has come through mainly putatively influencing neuroinflammation. And these may well have disease-modifying effects. I suppose, John, over to you. You've seen some of these trials in the reports. I suppose the first line, it is very exciting that we're beginning to get more trials in the DOB space, because we've had a real gap for a long time, and particularly disease-modifying therapies. And it's notable that one mode of action is via neuroinflammation, the other one is potentially influencing amyloid, and also maybe alpha-synuclein as well. Do you think that these are the directions of travel, and it comes back to use of, let's say, the MABs such as lecanemab for DLB? Should we really be putting our eggs in our basket and going there hard and fast on that first, or should we be concentrated on maybe the anti-alpha-synuclein agents, the MABs in that space?
Well, this is challenging question, and I know that some people in the field feel very strongly one way or another again the different MABs. To be honest, I'm very practical person, and I think if there is a mechanism that makes sense, it has to be tested, and then the results will speak for themselves. I think there is always a risk when you get too attached to your hypothesis that then you may miss things or you may misinterpret things. So I think You always need to objectively look and interpret the data. But I mean, I'm doing the CT1812 in Alzheimer's. I don't know if you were involved. Both of us were in the neflamapimod clinical trial. I don't know if you did CT1812 too. So, and I think it makes sense. So, one thing that is common to all neurodegenerative diseases is inflammation and gliosis and all these changes. So, and we are doing also here some neuromodulation clinical trials that are being investigated across different neurodegenerative diseases. So these are common mechanisms that could address multiple conditions. So the question is gonna, I think the answer is gonna be, I don't think there is gonna be a magic bullet. I wish there was, that is gonna treat everything, and we will just need to see how many different ones we will need to consider. So, and these were phase 2, so we need to get some more information. I think we have had many disappointments through the previous decades where there were promising phase 2s and then phase 3s were negative. So I'm always skeptically optimistic about the results and always trying to move forward the clinical trials. So one thing, going to the last first comment, is like I think in Parkinson's disease there is like a higher percentage of autosomal dominant and autosomic recessive mutations than in Alzheimer's. So I think there might be some ways through the genetic variants that tend to present more as Parkinson's disease to study these brain first groups. So I think it just takes some effort to get to the numbers, but there is some opportunities there.
Thank you, John. And I suppose this is a question which I'll pose to both of you. And John, you very nicely described the DOB consensus criteria, which have clinical and also neuropathological criteria. And there is also, of course, as you presented, there is the research prodromal criteria, dominantly within, elaborating on the mild cognitive impairment associated with Lewy body disease. I suppose those criteria are, they're recent, but they're getting a little bit older now. And, it is a question, I suppose, given that things are moving so rapidly in the field, we have these new biomarkers, we have these new ideas of the patho-anatomical characterization that Piers presented here. Do we need to reevaluate these? And if we do need to reevaluate them, where do we need to maybe make some changes? I mean, co-pathology, of course, keeps coming up time and time again, and that was there in the earlier criteria as well, particularly in the neuropath side. So I'll ask you, John, for your thoughts on this to begin with, and then maybe hand over to Pierre.
I think we will need to address. I think the group in Newcastle is better positioned to answer the question on your side than we do. But one of the things is, like, before, when you look at the criteria for Parkinson's or Alzheimer's or Lewy body, it took like over 10 years or longer to move from one version to the other. And what we are seeing now, for example, we have seen in Alzheimer's, is like we had clinical, so within like 10 years, we had three sets of criteria moving from research to clinical, moving very fast. And I think this is like what we are seeing now in the world with the advances in technologies, and I think collaboration and how things are moving, that the cycles move faster to incorporate. The question is going to be, and I think the criteria incorporate, because we have two different levels of biomarkers, and some of them might be moving groups. And I think the important thing is going to be evaluating the evidence at the time of the new criteria, and then being able to assign. But yes, I think that we need to include a move, and it's possible that this is very important too for clinical trials, because how we define the inclusion and exclusion criteria is heavily often dictated by the diagnostic criteria. So I do agree that this is something, and I expected it that maybe in January we would have had some discussions about it, but I guess we were not able to fit it.
Yeah, and it's definitely, if it's working, don't try to fix it. And certainly the criteria have been very useful for clinicians, and there is always a danger of over tinkering with these things. And I think that has been a challenge in the Alzheimer's space, with, because it's moving so rapidly. By the time that filters down to your day-to-day clinician, it takes a lot for them to change their mindsets. So I suppose that's balanced against the need, as you pointed out, very opposite need, that clinical trials need up-to-date diagnostic criteria which work. Pierre, I don't know if you wanted to add from your perspective or in regard to this question.
Well, maybe a little bit. You already, both of you, nicely summarized it, and you're both in a better position to speak about this regarding, clinical criteria and the need for having criteria that works in the real world here and now with patients that are seen by clinicians. So I think that's what makes it tricky. We need criteria that works in the clinic to a certain, there's no doubt about that. But my comment here would then be a little bit more futuristic and speculative, perhaps. And I tend to try to think about it in that way. I think that we should really try and embrace, going into the future, more of it like in cancer diagnostics, in oncology, and kind of try to, if we use a cancer metaphor and we take a cancer, like let's say a lung cancer. So a lung cancer has a silent phase, and it's very localized. So that would be the very early prodromal phase, preclinical phase of Lewy body disease or Alzheimer's disease. The pathology hasn't spread. It doesn't give you any symptoms. It's just there in a localized region. Then it starts to spread. And it can spread, it can choose different ways to spread. And it spreads further and further. So in lung cancer, sometimes your first symptom is that you start to cough up blood. Other times you might, you might have metastases in the liver or in your bones. So some patients, their first symptom is a liver symptom. Another patient, their first symptom is bone pain. Some patients get neurological symptoms because they have brain metastases. And then if you follow such metastasized patients a bit longer, some of those that have started out with only bone pain, then later they start to get problems with the brain as well, and liver problems and so on. At the end stage, they become more and more similar, because simply there's so much disease burden now that nearly all of the symptoms that you can have, you have them, right? It's a little bit simplified metaphor, but it's not entirely incorrect in my opinion. And, I think about spreading Lewy body disease and perhaps also Alzheimer's disease along the same line. So brain first kind of gives you one trajectory of symptoms in a certain order, simply determined by the wave of spreading. Body first disease give you in another direction. Then if you want to fit in, and body first gives you faster dementia. So sometimes that by itself gives you DLB, defined by early dementia. If you have Alzheimer's on top of that, you are even more likely to get DLB. But then if we wait another 5 years, 10 years, if you have Parkinson's disease and you wait 10, 15 years, they start to look a lot like DLB patients. And the DLB patients 5 years down the line also start to get autonomic problems and so on and so on. So they also become more and more similar. So that, so I guess my point here is that is kind of the drawback of the clinical criteria compared to trying to go strictly for biological criteria like in cancer, because a cancer doctor is not really preoccupied whether you started with bone pain or brain problems or liver problems. That's entirely irrelevant in a way. And perhaps perhaps that's the way that we will be able to go as well. That at the end of the day, that's not really what's the most important thing. The important thing is to understand, are there differences between what ends up giving you DLB versus PD, and understanding it so thoroughly that we can pick it up so early that we can actually treat it. And then it doesn't really matter if the end stage looks like DLB or PD so much. Obviously, if we can treat it, we don't care. So I mean, anyway, sorry for that long rant, but do you have any comments to that?
So I'll just respond to that. I think it's, again, you're speaking very much that, we have traditionally focused in because all the tools we had were clinical. So therefore we had to develop clinical criteria. But that is, as you say, is the sort of the distal end of a journey which has happened, and there's been quite a lot on that journey. So therefore a better awareness of the full spatial temporal, pathological journey is necessary for us to understand and therefore develop treatments. And I think at the moment we are somewhat, we aren't operating in a continuum here. We are making sort of very specific classifications rather than taking a look at things in a dimensional way. And I think you're also alluding to a sort of more precision medicine based perspective where perhaps people are expressing different dimensions of pathologies, or certainly whatever is the ground truth of causing etiologically these conditions. And that will help then decide for an individual. Maybe we will have signatures or motifs for individuals, and we will then personalize the treatments according to that at that early stage. And I think that, there's a follow-on question from Santra, and it's really talking about the exciting possibilities of using biomarkers, whether that be imaging or CSF, to enhance our sort of diagnostic accuracy, and asking, that's happened in Alzheimer's, can it happen in Lewy body dementia? I suppose I would immediately say that we've probably been a little bit ahead of the curve in DOB by integrating biomarkers at an early stage as part and parcel of the diagnosis. And we know that things such as the DAT scan and MIBG have got a pretty good sensitivity and specificity for delineating DOB. So I suppose, but, John, I don't know if you want to say, is there, with the synuclein assays and the skin, immunofluorescence, etc., whether we're going to get a further gain on that? I would probably say yes, particularly at this earlier phase, but would you like to comment?
Yeah, I think I have here the luxury of the question, but that is written. But what they were saying is like before amyloid and PET, like the I guess diagnostic probability, which I'm going to interpret as accuracy, was 50% in primary care and 65% in specialized neurology care. I think for the neurology care, it seems a bit low. I would say at least at the dementia stage. Like other studies have shown like around 80 to 90%, and this was shown in like the Alzheimer's disease dementia clinical trials. The question is, as we are moving to earlier and earlier stages, like the probability or the prevalence of Alzheimer's disease pathology is lower, and then it will depend on the clinical phenotype that we see and also on the age. So usually I always say when I see people in their 80s, it's tricky between late and Alzheimer's. MRI and clinical phenotype might be very different. But I mean, we are not talking about Alzheimer's today. But I think this is also what is going to happen in earlier cases. For example, when we have single episodes of altered mental status in a hospital admission, when we have some late onset depression without a previous history of depression, I think in these cases it's going to be difficult. Otherwise, when we see probable DLB, the autopsy studies have shown pretty good specificity for the diagnosis. I think the challenge is going to be more in the earlier stages, and I think here is where biomarkers are more helpful. I just wanted to jump a bit back to what Per was saying before, and regarding like how to classify and to look at disease. And I think ideally, if at some point we have an very accurate screening test, and then we can figure out who needs to be screened, and we can basically identify the disease before like the whole picture of symptoms appear and treat it successfully, then at this point, maybe the clinical phenotypes are not so important because we are not going to see them anymore. It's like when you study medicine, and I had like some of my books of my father or my grandfather, you would see some pictures of the 1900s or 1800s, and we don't see disease like that anymore because their surgeries and everything have advanced and the antibiotics. So it might be that I don't know how many decades or years down the line things may look different. But I think at this point, from the clinical aspects, because when you see, well, if you have a test, you have positive Lewy pathology, so does it matter what Parkinson's disease, PDMCI, DLB? Well, I think from the prognosis is different for all of these conditions. The what families and people living with these conditions are going to encounter is different. And unfortunately, we are at a stage where we mostly have symptomatic treatments. So I think like how you are going to manage this is going to be different. I think you early on alluded like how treating some symptoms may worsen other ones, or how we need to deal with the side effects of some medications. So I think everything is important now, and the problem is because especially in DLB, we don't have disease-modifying therapies. Clinical phenotypes are still very relevant because we can give some prognosis, and families can plan. And then we often, I mean, when I see people in clinic, I may say, well, you may not see this, but this might become a problem in the future. Or, for example, try to find people who have gait instability very early, get them like aggressive with physical therapy, changing things at their home to prevent falls. Because once they have fallen and break a hip, it's going to be very difficult to go back. So I think that's why clinical presentations give us a roadmap of what may come in the future. Also for management, in the future, as we are able to detect things earlier and hopefully slow down, it may become something of history books. But unfortunately, we are not there yet.
Thank you, John. Here, can I ask a very specific question, which is, sort of intrigues me, and that's, and John mentioned it as well, and that about hyposmia, which clearly has a very strong linkage with positivity on the SAA. Hyposmia, you know, to my sort of simple way of thinking, I think, oh yeah, nose, we're going to lose, you know, we're going to be hyposmic. But in actual fact, your suggestion is more the body first might manifest the hyposmia as opposed to the brain first. And I just wanted to get your thoughts on that to understand that.
Yeah, thanks, JP. First, I can say that, you know, the clinical evidence for what you just said is very strong. So in the sense that if you have Parkinson's disease and it started with RBD, the sleep symptom, 10 years ago, so that will make you body first. You have more hyposmia than if you don't have had RBD 10 years ago, and then you were brain first. And the same goes for the MIBG heart scan. We know that as well. If you have an invisible heart in early PD, you have a much worse hyposmia than if the heart is still normal. So it's kind of the opposite. It is with these things strongly support that brain first develop less hyposmia earlier than body first does. And that's strange. So why might that be? And I mean, again, I don't know, but my main hypothesis is based on 2 post-mortem studies. And then I need to say that when we say hyposmia, what we mean is that we have been tested by an identification test. So you smell something, and it might smell of garlic, and then the patient gets 4 choices. Is it garlic or engine oil or roses or something? And then they choose one. And to make that test, that's not only an olfactory bulb test, that's also olfactory memory and semantics and kind of a cognitive test. And that's what we call hyposmia, most of us. But it is actually more than just the olfactory bulb. Okay. Anyway, the point from those 2 post-mortem studies, and there are 2 of them, and they showed the same thing. they tested for hyposmia in people just before they happened to die. And then they died, and then they were examined at postmortem. And then they looked at the olfactory bulb and quantified how much Lewy pathology is there and how much Alzheimer pathology is there. Okay, and what they found is there was no correlation. So there's no correlation between the amount of pathology you have in the olfactory bulb and whether you can smell or not, just before you died. Okay. However, when they then quantified the amount of Alzheimer pathology and Lewy pathology all over the brain, they found that the only thing that really correlates is that if you have a lot of Lewy pathology all over the brain, that correlates. The bulb does not. So if and two independent studies showed this. So that tells us, if that is true, that tells us that the next time we see a patient and he has hyposmia, we have actually learned nothing about the olfactory bulb, but we have learned that there's quite a bit of widespread Lewy pathology. And the brain-body hypothesis baked into the idea is that early body-first disease, they have more widespread Lewy pathology, they have a higher burden. So that actually, that can explain those two postmortem studies actually fit with the idea, and also the postmortem data on brain first and body first that support that they have more pathology. So that's the only explanation I can come up with.
So you're suggesting it is at a higher level, not within the olfactory bulb, but within the higher cortical levels, which associate with sense of smell, or how we perceive smells.
Simply a higher global burden of pathology inside your CNS, then you start to get hyposmia. At that level, almost everybody will also have it in the nose. But the reason for why they couldn't see that correlation is because if you have nose first or very early brain first, so that's limbic first, you'll have lots of pathology in the nose, sometimes in the olfactory bulb, but you have very little elsewhere. And those patients, many of them had normal olfaction. So it kind of makes sense to me based on those data.
Very intriguing indeed. John, can I just take it back to you? I mean, you're a champion for co-pathologies in DLB, and I suppose we talked quite a bit about Alzheimer co-pathology, but I just wanted to get your reflections. I often feel that they sort of like the neglected people at the party that nobody wants to talk to, vascular, and now we know TDD43, the guy sitting in the corner. Can you sort of put them in context of DLB, and what should we be doing about these other pathologies and how we look at DLB?
Yeah, so vascular, I think it has been, as you said, always very neglected, and because a lot of the exclusion criteria for the diagnosis were, well, you need to exclude vascular pathology. So basically, for many years, anyone who had like any stroke or any subdural, epidural, or hemorrhage were excluded from brain banks. So I think we have selective, or even from inclusion in clinical studies, because MRI, I think it has been the longest successful biomarker for one of these pathologies, namely vascular. So we have been able to see it for many years, and that has been an exclusion. And so this has been something that is tricky. Also, vascular might be also related sometimes with socioeconomic risk factors, and these might be people that not always can or participate in studies. So, but I think, and then there is also like frequency and potentially some mechanism of vascular neurodegeneration. So they are there. Fortunately, we are able to detect it very well. I always say it's easier to quantify on the MRI than on pathology, although now with digital pathology, things may change. Still, you would need to do a lot of sanctioning. So I think MRI is still going to be better. And I think TDP43 problem is we don't have any biomarkers. So it's still there is some patterns of FDG that are suggestive of late, But the thing is, they only work when you don't have adipopathology, and very often they are present. So I always say, like, late is a diagnosis of exclusion, and even in some cases is there, and we are not going to be able to predict who has AD versus AD plus late. So, and I think still there is like quite a bit of challenge in terms of TDP-43 biomarkers. But I think vascular, we should do a better job taking it into account and recruiting the people who also have these pathologies as a whole. I think often we are working in silos, where it's like the AD group, the DLB group, the vascular group, and I think the question is how all of this is put together. I think the pathologists have been the ones that always get the whole picture.
Thank you, John. So I think we're nearly at time. So I'm going to ask you both to make a final comment. You know, what is perhaps priority for DOB? And I suppose relating back to my original question as a clinician, dealing with this heterogeneity, what would be your final comments? Maybe Pierre first.
Yeah, well, that's a $1 million question. But anyway, you know, I think what many of the groups in the world, including my group, is trying to do is to make the best possible studies that we can do. And by that, I mean that we try to collect as much data from each patient as we can with scans and blood and etc. And simply just study and study and study. And then we follow the patients so we also know how are they different clinically and how do their trajectories. Because what we are trying to do is we are trying to understand the underlying genetics and other mechanisms that determine those different trajectories. Because once we get there, we can actually start doing more targeted treatments, also clinical trials to prevent disease or at least modify it. We can do that in highly selected cohorts. And I think that, I believe at least that is tremendously important if we're going to succeed.
Totally agree. We need more deeply phenotyped longitudinal cohorts for DLB. It's been a real gap. John, final comments, thoughts from you.
Well, I guess recently we had the milestones of the NIH, and I presented two. One was like the clinical cohort, and I think I will fall on the other one we put first, which was clinical trials. So I think we need more clinical trials, and we need to have better scales and better designs for clinical trials in DLB. I have a lot of clinical questions and research studies, but I think we have a lot of pressure to try to get and deliver the next generation of clinical trial designs and treatments.
Thank you, John. So a huge thank you to both of you for that, you know, exegesis of DLB covering lots of different topics. And again, big thanks to Ace Global for hosting us and allowing us to talk and also address the questions. And a big thank you to our audience members as well for listening and posing questions. I think it's now time to wrap up. So again, thank you.
I won't cry, no I won't shed a tear, just as long as you stand by me, and I